So our next speaker is Matt Adler, who's Richard A. Horvitz Professor of Law and Professor of Economics, Philosophy, and Public Policy at Duke University. His work focuses on three areas: policy analysis, risk regulation, and constitutional theory. And he's the author of the recent and superb book, Well-Being and Fair Distribution.
Thanks very much, Peter. Thanks, Mark, for that wonderful talk. I gave a full, indeed overly long version of this early in the morning. Fortunately, most of you were not here to hear that. Norm, unfortunately, did have to hear that. So if only it's to be nice to Norm, I'm going to try to make this a little shorter. And I'll be talking about equity, a term everyone in the room has thought about, Pareto, but also this idea of Pigou-Dalton, which maybe is not familiar to everyone here. That is great. All right, so let me just give an overview. Like Peter, I know nothing about universal coverage. Well, after being at this conference, I have to apologize I was not here yesterday, but I've learned a little bit today. But I don't have well-formulated views about universal coverage. So rather, I'm going to talk about methodology. And this talk may feel like a talk from 30,000 feet. I'm not going to talk in detail about where to locate ourselves on the cube, but rather about methodology for determining what the optimal or acceptable set of locations on the cube, or if it's a four-dimensional space, the four-dimensional space is. It turns out, the good news is that equity is actually measurable. Right? They're actually quantitative, not just qualitative tools for thinking about the degree of equity. The bad news is there are lots of them. There's a plurality. So we have to think now, if we're in this business of using quantitative frameworks, and I want to suggest that we need to do that, even if one is working within a broader kind of deliberative democratic framework, right? This is useful information. So then we have to think about which one to use to assess where to be in the cube. Now, what's interesting is that this Pigou-Dalton principle, and I'll give a statement of it in a minute, in some form is the heart of any equity metric, in some form. If one looks at standard health equity metrics, and I'll talk about those in a second, and these will be familiar, I think, to everyone here, those satisfy this Pigou-Dalton principle with respect to health. Or to put the point another way, they take health as the currency for distributive justice, for equity. Now, for the welfarists, and I think it's fair to say that Mark, Peter, and I are all welfarists, this is at least theoretically problematic, right? At least theoretically it's problematic because well-being depends not just on health, but also non-health attributes, consumption, and other kinds of non-health attributes, right? So at least in theory, it would be better to have well-being as opposed to health as the currency for this Pigou-Dalton principle. Also, it turns out that these various health equity metrics can violate the Pareto principle, right? Now, I'm not sure that everyone in the room likes the Pareto principle. I know at least one person who's on record is not liking it very much. Where's Larry? He's left. But to lots of us, the Pareto principle seems quite plausible, and I'll talk about that a little more. And here I'm very much on board with what Mark was saying, and thanks for the kind words about my book. At least in theory, an equity regarding, that is, Pigou-Dalton respecting social welfare function, and we've heard about different possible forms, applied to utility, that is the measure of well-being, where utility is interpersonally comparable, would be better. But it may not be so easy to construct this utility measure. All right, so the PD principle, Pigou-Dalton principle, named for Pigou, perhaps better known for his notion of Pigouvian tax, and Hugh Dalton, a great economist and the British Treasury Secretary, says that a non-leaky, gap-diminishing transfer of an appropriate currency, and again, this is a generic principle which can be applied to different kinds of currency, health, income, utility, happiness, But the PD principle applied to the currency says that if we can transfer some of that from someone who has more to someone who has less without losing any, and the transfer is not so big as to increase the gap between them, that's an improvement. Right? So this is just a simple example here. Here we're transferring 3 units of this, whatever it is, again, health, income, utility, right, from the person at 16 who goes down to 13, and the person at 8 who goes up to 11. And that, at least if the currency is appropriately specified, seems more equitable. Now, it's crucial here, again, that the gap diminishes, number one. If the gap increases, the intuition about equity is weaker. And also, this is not leaky. Now, one might be willing to tolerate leaky transfers. Indeed, part of the issue about the degree to which we appropriate lex and min is the degree to which we're going to tolerate leaky principles. But it seems true or intuitive that at a minimum, in the kind of limiting case where we can have this non-leaky transfer, that's a good thing as a matter of equity. I like to think of PD as Pareto's sort of kinder, gentler cousin. Right? We're all familiar with Pareto. And PD, in effect, is the Pareto principle for equity. It's a way to formally capture what equity is about, just as Pareto is the heart of efficiency. Pareto, again, says this is what social choice theorists describe as, quote, strong Pareto. If everyone weakly prefers an outcome, right, so everyone either prefers it or is indifferent to a second outcome, and some strictly prefer the outcome is better. Right? Now, again, we can argue about whether that's an attractive principle or not. I'm going to take as given that it is. And again, we can talk about people's well-informed preferences if one is concerned about that. You can formulate this in terms of suitably idealized, deliberative, well-considered preferences. So one might think of these as being twin principles. One interesting difference, however, is that it seems like the PD principle has lots of different versions. One doesn't hear about lots of different versions of the Pareto principle. Maybe there are a couple of different versions, but PD, it turns out, comes in lots of different versions. I'm going to have a paper shortly out on SSRN, the academic website, that goes through this. I won't go through this in great detail here to spare time, but if one looks at various equity metrics, so income inequality metrics, income like the Gini, income poverty metrics, the so-called Foster-Greer-Thorbecke metric is one of those, measuring degree of poverty. Health equity metric, I'll talk about those in more detail in a second. Social welfare functions, or more specifically, equity regarding social welfare functions like the prioritarian or lex and min and others. Or even this newer class, there's this new literature on so-called multidimensional metrics that look at the distribution of attributes in multiple dimensions. All of these satisfy this PD principle in some currency. Income inequality metrics do so with respect to income. The health equity metrics I'll talk about a little more in a second do so with respect to health. Social welfare functions do so with respect to utility. The other interesting point is that this principle can be true in a kind of an unrestricted fashion or a restricted fashion. So what's interesting is that, if one looks at this idea of the poverty line and measuring poverty, there is something which, Amartya Sen, a great pioneer here, as elsewhere, called the focus axiom. That is, transfers above the poverty line make no difference to the degree of poverty. Right? If you increase the income of someone at the level of 50,000 by 5,000 and decrease the income of someone at 100,000 by 5,000, if 50,000 is above the poverty line, that's not going to change the degree of poverty. So there's a sense in which this satisfies PD. It will satisfy PD, tip the FGT, for example, satisfy PD with respect to transfers from someone above to someone below and between people below the poverty line, but not over. As I'll talk about in a second, there's a standard health equity metric, the concentration index, that also in a different way has a kind of restriction on the PD principle. Okay, so let me just talk quickly about these inequality metrics applied to health. Now, I'm sort of an outsider here, but I take it, there's an ongoing, started a couple years ago, dispute among health scholars as to whether one should just use one of these kind of population-wide inequality metrics, like the ones that originate in the income inequality literature, like the Gini or the coefficient of variation or the Atkinson or the Thiel, and apply those to the population distribution of health measured as longevity or Dowley adjusted longevity, what have you, as opposed to a kind of a social gradient approach, right, which looks at the association of health with some marker of social status. Now, that's an important debate, but let me just step back from that. What's interesting is that both of those approaches, as well as the approach of using qualities or dollies with equity weights, which Oli talked about, all three of these, so these I'm going to have up here as sort of the standard health equity metrics, at least in scholarly discussions. I'm not sure how much this has been operationalized, but certainly there have been discussions about this. All three of these satisfy the Pigou-Dalton Principle with respect to health, right? Inequality metrics, I mean, it's a feature of any inequality metric, a defining feature. Whatever the differences between the Gini and the coefficient of variation, they all satisfy the PD principle. And so if applied to health, they're going to do that. Quality-based cost-effectiveness analysis with weights. Now, again, I'm assuming, as Mark said, that the weights are a function of health. And in particular, let's assume, I think quality, dollies would be the same thing, right, that we give greater weight to quality changes for those at a lower quality level. That's, in effect, what you were talking about, right? This obviously is going to have the effect of favoring a Pigou-Dalton transfer in qualities, right? And so, think of this as the choice between two programs, right, P and P star, which have the very same costs, right, and the same quality gain, right? But P delivers the gain to people at a higher level of qualities, P star to people at a lower level of qualities. So if one moves from P star to, if one moves from P, which delivers the quality gain to people at a higher quality level, to P star, right, one in effect is transferring that gain to people at a lower quality level. PD in health says to do that. And if one is doing a quality-based CEA with equity weights, that's going to be favored. Finally, this health concentration index, which I think is related to, in part to what Davidson-Watson was discussing earlier, may be familiar to many people here. Basically, this is like the Lorenz curve, but the difference is that people are rated along the x-axis in terms of some marker of social status. Can be socioeconomic status, might be racial status, could be some marker of social status. This is the cumulative population share. So here's an example in which we have groups, three different social status groups, low status group G1 here, G1, G2, and G3. G1 is 25% of the population. G2 is the next 55%, so 80% cumulative share, and G3 is the next 20% of the population. On the y-axis is their cumulative share of health, right? So G1, although 25% of the population, only has 5% of cumulative health and so forth, right? And the concentration index basically measures how far down this is pulled. The more this is pulled down towards this vertex here, the more health is concentrated among people with higher social status. Now, it turns out that this satisfies the PD principle with respect to health for transfers from people at a higher social status to people at a lower social status. And if you, I'm not going to do this now, but if you go through this formula for the concentration index, that becomes obvious. So if you choose a program that improves the health of someone in G1, in lieu of choosing a program that improves the health of someone in G2 or G3, that's going to decrease the degree of concentration and be seen as an improvement. On the other hand, if you transfer health between members of the same social group or in reverse order, that will not change or even increase the concentration index, and so will not be seen. So there's a sense in which, again, we have PD, but now in this kind of restricted form. All right. That's an explanation of all these metrics in terms of this unifying idea of PD. But now we have this question, which is not really analogous to Pareto. What's the right currency? Right? And, someone I think a lot of people here know or have heard of, Dick Arneson, has a famous article, titled "Welfare Should Be the Currency for Justice." And that, in effect, is what I'm saying here, where PD is just a kind of an axiomatic expression of what justice or equity is. I want to say, and again, I go through this at great, boring detail in chapter 5 of my book, that it seems to me that the best justification for this PD principle is that someone at a lower well-being level, right, whose life is worse, all things considered, has a stronger claim to a well-being improvement, at least leaving aside responsibility. Right? Of course, it's possible that someone at a lower well-being level is badly off because he or she is screwed up in some way. Right? But leaving that aside, right, and there are systematic techniques for taking account of that, and Mark has pioneered that, but leaving that aside, it seems to me that well-being is or it's well-being disparities that state the strongest kind of case for the PD principle. Although, as Peter points out, certainly one might take health as a proxy for well-being. It's not a perfect proxy. Right? Health correlates with other well-being relevant attributes, but the correlation is not perfect, particularly if we think of those attributes as being not just income, but leisure, social life, status, environmental quality, and so forth. Happiness, right, is one component. Someone can be at a low health level, but be pretty well off, all things considered, because of all these things, or vice versa. A related point is that, at least in theory, a transfer in health, which is non-leaky, which is a pure transfer, might be a leaky transfer in well-being. Now, that doesn't seem to be likely where the person who's at low health and high health have the same background characteristics, but when they have different background characteristics, that's at least theoretically possible. And so, again, it seems like PD in health is less attractive. Now, one might say, well, it's just a good enough approximation. But let's remember, folks, this is the era, and this goes to Mark's point about empirics. We're in an era of big data, right? If we were in an era of small data and weak computers, I might say, yeah, let's take health as a proxy. But now we're at a point where we can see or at least model how health and non-health attributes interact at a population level and across the population. Why not do that? Right? Why just use the proxy where we can get closer to the first best? The final point is that, a structural point, this Pareto principle, in practice it may not be the case that we're ever going to choose a policy that makes everyone worse off. But if one sees as a kind of an axiomatic matter, right, that a metric can violate the Pareto principle, that seems to be a structural failure, right? It's sort of like finding out that some kind of logic generates a contradiction, or that some kind of axiom system in math generates a contradiction. That's a reason not to, ceteris paribus at least, not to buy into it. And that, I think, is at least one thing which should be noted here about these health equity metrics. Okay, so here's an example. Again, maybe this is just a theoretical point, but how quality-based cost-effectiveness analysis, and here I should say this is true both of, this example I think works both for regular cost-effectiveness analysis, but also the weighted kind that Oli was talking about, how this can violate the Pareto principle. And I'm going to illustrate the model using a very simple utility function. Right here, utility is a measure of each person's well-being. This is just an additive. Economists sometimes, it's a very simple matter, use an additive utility function. So it's a function of income and health. I'm making it be logarithmic income to reflect plausibly the declining marginal utility of income. We can talk about this weighting factor, but this actually gives a very strong weighting to health. Let me say, though, that one could generate a similar example with lots of different utility functions. Right? What leads to the example, what leads to the violation of the Pareto principle, at least the principle, is that there's heterogeneity in trade-offs between health and income. Now, it should be clear, right? That kind of heterogeneity is not the same kind of heterogeneity that Mark was talking about. I mean, maybe we need to worry about heterogeneity in preferences themselves, maybe not. But even if we assume that everyone has the same preferences, right, over health consumption bundles, presumably people are going to be at different levels of those. That is, the indifference curves are not linear. There's some curvature to indifference curves. There are going to be different rates of substitution between health and income in producing utility, and that can generate, this utility function just shows that in a simple way, that can generate a Pareto problem. So here, so you can think of Q star as a program, think of these as two kinds of targeted programs, right? Programs that target either someone at a higher income, someone at a lower income, right? Where the costs are borne by the beneficiary. So program Q star is going to reduce this person's income by $100,000 a year. It's just, a simple numerical example, but improve her health. If you, as opposed to program Q, which would reduce this person's income by $40,000 a year, and improve her health by the same amount. Now, if you do the utility calculus using this function, it turns out that they're both better off here. They have higher utility here. Right? But what's interesting is that as a matter of quality-based cost effectiveness, whether or not one uses equity weights, and again, equity weights aren't relevant here because they're at the same levels, right? Program Q is chosen. Indeed, program Q is chosen regardless of the cost effectiveness threshold. So what's going on here? What's going on here, of course, is that as a matter of health, this is a wash, right? We gain 0.05 unit of qualities here, and we lose it. Right? So if we add health across the population, and again, because the levels are the same, their equity weighting doesn't change this. So it's a wash in terms of effectiveness. But there's a net cost. Right? We lose 100,000, and we only gain 40,000, so we lose 60,000. So if one does a CE ratio, it's infinite. It doesn't matter where you set the ratio. If you do cost-effectiveness analysis, this is worse. But as a Pareto matter, this is better. What's going on here? The problem here, and this goes to Mark's slide, I think one problem, I think he said this, but let me just emphasize this. A fundamental problem, it seems to me, with quality-based cost effectiveness, even with weights, sorry, is that we're adding up health, perhaps weighted across the population, we're adding up income, but we're not looking at how they interact within individual lives, right? And that interaction is heterogeneous, that's the point. In theory, we want to capture that. Right? If we care about well-being, indeed, this will be true even if one didn't care about preferences. Any measure of well-being, once there's heterogeneity in terms of how they interact, right? In theory, what you want to do is add up health and income at the level of the individual life, right? And then distribute that across the population. And because quality CA doesn't do that, we lead to violations of the Pareto principle. Now, I was trying to think about whether one could produce similar violations with the other tools, but it occurred to me, there's actually a very easy example. Right? Take any case in which you target a health program at people in poor health, but they bear the cost of that. Either they bear the cost directly or the tax system is such that the ultimate incidence of that is on them. And assume that, given their utility, they prefer not to pay that. So we have a Pareto reducing move, but the inequality metric applied to health is going to say we have an improvement because people with lower health are being moved up. And similarly, if they're at lower social status, an index like the concentration index will say it's better. So I think all of these metrics can have a violation of the Pareto principle. And in this context of you see, at least in contexts where it's the patients who themselves pay, either in the first instance, they're ultimately given the tax system, right? And here Mark's point about how are the funds raised is very important. This anti-Pareto feature may be more than just theoretical. All right, so let me, others have talked about the social welfare function framework. The idea here, again, is to have a measure of well-being utility, right? This has got to be interpersonally comparable. Right? So what we're doing is taking outcomes, you think of outcomes as descriptions of the different kinds of attributes, health, non-health, income that people get. We have a utility function that takes all that information about attributes and simplifies it to one dimension. Right? One utility number, this is interpersonally comparable. So if U1x is less than U2x, that's supposed to mean that person 1 in outcome x is worse off than person 2. And again, the nice thing is that in principle, we can add up all these different contributors to well-being within each individual life and capture that in this number. Now, this is kind of the theoretical ideal. I said here before, this is a measure of well-being. That's consistent with any kind of well-being. One could have a kind of perfectionist account. An Aristotelian account that doesn't care about preferences at all. One could then measure that with a U function. But if we care about preferences, it would be nice to have a U function which is preference respecting. That is to say, this U function intrapersonally tracks each person's preferences, or if you want to launder the preferences, each person's idealized preferences. That is to say, if UIX is greater than UIY, that's going to be true only if, just in case, I prefers X to Y, and that utilities of two outcomes assigned to the same person I are going to be the same if and only if the person is indifferent. So the nice thing is if U is preference respecting in this way, and this function W is mathematically increasing in each person's utility, right, then W will satisfy the Pareto principle. In addition, there are lots of different kinds of W's that satisfy the Pigou-Dalton principle. Now here this is going to connect with Peter's talk. If one carves up the space of social welfare functions, and one starts by sorting between social welfare functions that satisfy or don't satisfy Pigou-Dalton, utilitarianism doesn't, because utilitarianism just adds up utilities, right? So transferring utility from someone better off to someone worse off is just a wash. But there are lots of kinds of social welfare functions. Now, I happen to like, this Atkinson social welfare function because I like all these axioms. But that's, let me just step back. We can argue about all these axioms, but once one buys the basic case for Pigou-Dalton, right, that someone who is worse off modulo responsibility is a stronger claim to well-being, right, there's then a whole big part of the social welfare function space that can satisfy Pigou-Dalton. Prioritarian social welfare functions, Lexamin, Peter mentioned a kind of a prioritarian social welfare function with a threshold. The rank-weighted social welfare function, which corresponds to the Gini coefficient. All of these are ways to satisfy both Pareto, at least if the utility function is preference-respecting, and Pigou-Dalton. Now here's the tricky part. Let me stop here. And this is, Mark says, well, let's assume preferences are all the same. Or maybe you don't need to worry about that. If people have the same preferences, then it's very easy to do this. What seems to me to be really tricky and difficult is if that's not the case. And so, for example, in the case even of a poor population, it seems to me you need to take account not just of the beneficiaries, but of the taxpayers. Maybe they have different preferences, right? Once we have that, how do we come up with this utility function which will both make sense of interpersonal comparisons but also be preference respecting in the individual case? That's difficult. So I'll skip over this, which Alex is going to talk about, and say that we have a theoretical ideal here, which I think a number of people in the panel sort of agree with. That is to take the expected value of a social welfare function, which is both equity regarding in terms of the PD principle, and paration, at least if utility is preference respecting. But I'm not sure we're there yet in terms of, in particular in terms of doing this, or for that matter, at the level of detail of choosing within this space.